Good evening from New York. I'm Selwyn Collins, your host of CWS Journeys. Thank you for joining us this evening. My guest this evening is Dr. Oneeka Williams, who is no stranger to CWS. But I'm especially glad to have her here this evening because we have been trying for some time now to get her to find a suitable time for her to appear because of the topic tonight, cancer, prostate cancer in the Caribbean.
And one of the things that I have been, very excited to see when we think about what's happening with prostate cancer in the Caribbean is that, there have been a number of studies that have been done over the last 10 to 15 years that have looked at these populations, that have looked at some of these issues, and that have accumulated data. Because when we make decisions about what should be done in terms of medical management, medical treatment, medical diagnosis, we like to have what we call evidence-based, we like to practice evidence-based medicine. So we like to see data and statistics that support our approaches, that support the way that we think about management and treatment of disease processes. And so one of the studies that has been ongoing over the last, I think since 1997, has been a collaboration between the Tobago Health Services Unit and the University of Pittsburgh School of Public Health. And this came out of a realization, back in the early 90s and 1995 when the Ministry of Health of Tobago did a health assessment of the overall population, the overall health of the population. And what they found was that there was a significantly elevated incidence and mortality related to prostate cancer. And so with that information, they then sought to understand, what the incidence and the prevalence was of prostate cancer in Tobago. And so with that having been said, they created a study where between 1997 and 2001, they screened almost 3,000 men, which was probably almost about 60 to 70% of the population of men in Tobago. And they screened those men with drawing their PSAs and doing the digital rectal exam. And what the information that they took away from that study, and we followed these patients, through to even to recently as they continue to gather information, was that 42 of the men that they screened, 30% of those men, had some type of abnormality. And of that 30% of those men, almost 30% of those people were actually diagnosed with prostate cancer. And so of the 42% of the people then who were biopsied and almost 50% of those men had prostate cancer. And so that's a significant, when you look at the lifetime risk of prostate cancer, that's a prostate cancer risk, certainly for men over 50, was a prostate cancer risk of 17% of prevalence of prostate cancer in that small island. And that's very significant. And so that we have been able, or at least that they have been able to accumulate and gather that data and follow those patients over time has been extremely helpful as we look at the need for screening in the Caribbean because of the high prevalence. And when you look at Jamaica, you look at Barbados, you look at Guyana, this is reflected in the powerful WHO study that was just released in 2013, where the incidence and the mortality rate from prostate cancer is among the leading in the world. So the need for screening in the Caribbean is emphasized and supported by these studies that have been out.
In the chat room, John asked, what is a good PSA number?
We currently have what we call sort of age-specific ranges. If you're less than 50, we'd like to see your PSA less than 2.5. Between 50 and 70, PSA of less than 4. And if you're over 70, we'll accept a PSA of up to 6.5. Now, this is in combination with the combination of a digital rectal exam. So knowing the PSA, in addition to knowing what the digital rectal exam goes hand in hand if you have a normal PSA, in other words, if you're 60 and your PSA is under 4, but your digital rectal exam is abnormal, then there is certainly a suspicion of is there an abnormality in the prostate that could represent a cancer, even though your PSA is normal.
And one last question before we go on a break. Lynn asks, how do I get my husband, 56, to go get tested? He's scared of a doctor putting a finger in his butt.
Right. And that has been, and that is certainly one of the issues, especially within the Caribbean. The stigma attached with, digital rectal exams, the stigma attached with, this expectation that it's going to be something that's, very uncomfortable, that's very abnormal. And a lot of men in the Caribbean have, a bias against having digital rectal exams. And, part of doing these type of awareness type of shows, Selwyn, I commend you for, really sort of your commitment to sort of highlighting these type of issues, is providing the information and providing the education and the reassurance that if you are able to identify something like prostate cancer early, then it is very treatable and it is curable. And I think the sad thing is that what we see certainly within the Caribbean is that many men who present with prostate cancer present with metastatic disease by which time it is way too late to really to sort of offer anything that is curable. And so, I think for many men, the studies have shown that the men who actually do better for prostate cancer and who are diagnosed earlier are men who are married. Men who live longer are men who are married, and that's because though they have wives who are behind them to get themselves checked, to see the doctor, to be checked out. And so I would just encourage her to just really continue to just hammer home to her husband that something that can be dealt with early is less likely to be something that is life-threatening or that will end up with having you die from prostate cancer. And so going through something like a rectal exam, which yes is not the most comfortable thing, but for many people, there's a stereotype that it's not something that is a normal normal part of an exam, or it's not a very comfortable part of an exam. But the preference would be to have a rectal exam and to deal with that sort of very short-term discomfort than to deal with metastatic prostate cancer, which the treatment for which is prolonged and protracted. The treatment can lead to very many complications, and that there is no cure. There is really treatment, but that eventually with metastatic prostate cancer you would likely die from prostate cancer.
Okay.
So I would choose a finger in the butt.
Let's take a quick break. We're back with Dr. Oneeka Williams. In the chat room, Dr. Williams, Lynn asked, why should Caribbean men be concerned?
I think Caribbean men should be concerned because this is a disease that's very treatable, and that to have a disease that is treatable and have men dying at such high rates from a disease that if it's identified early, that can be treated and can be cured, I think Caribbean men need to be concerned about, the reality of dying from a disease that really and truly, in most circumstances, should be identified early and cured.
And Lynn asked again, are you in private practice?
I'm in a group practice at one of the hospital systems here in a sort of a tertiary academic center with a group practice within that institute.
What are some initial reactions you see when you notice in men when they realize that they have cancer, prostate cancer?
One other thing I wanted to mention, Selwyn, before I respond to that, when you asked about one of the most common questions that I get when men are asking about prostate cancer. One of the other things that sort of comments is that, well, I have no symptoms. So if I have no symptoms, then why should I be concerned about prostate cancer? And so that's one of the distinct differentiation that we make, which is that early diagnosis is asymptomatic. Early prostate cancer is asymptomatic. by the time that you develop symptoms related to prostate cancer, it usually means that the cancer has already spread outside of the prostate. And so, you know, that is something that I hear a lot. I have no symptoms, and so you don't want to have any symptoms. If you have symptoms, it usually means it's too late. And
No.
so when we talk about how do men respond when they find out that they have cancer, certainly I think one of the barriers to developing, or one of the barriers that it could be checked and screened for prostate cancer, is a fear. It's a fear not only of undergoing cancer treatment, but for many men, and they hear a lot about this in the media. Um, they worry about erectile dysfunction and incontinence. And certain erectile dysfunction is a very big part of what men worry about when they think about being treated for prostate cancer. And so one of the very, the questions that, first of all, just sort of dealing with the shock of, okay, I have cancer. Well, what does this mean for me? What does this mean in terms of my ability to function? I don't want to have cancer. I'd like to, to live a long life, but it is very worrisome for men to think about not being potent or having to have issues of urinary leakage, which can be related to, the treatment for prostate cancer. So, those are some of the very initial concerns that men express. Now, because of much more education and much more awareness, and certainly a lot of the publicity surrounding the overdiagnosis of prostate cancer, many men will come in and they'll say, but I heard in the news that a lot of men after a certain age will have prostate cancer cells, and that it will never become a problem. And so, do I really need to be treated? Is this really a problem? And so that's a very common response because of a lot of the information that has been available about clinically significant versus clinically insignificant prostate cancer.
Wow. And Brian asks, do you have a hard time convincing Caribbean men to get exams, and what kind of excuses you usually hear?
Well, certainly one of the primary ones, as we said, is that, well, either no one in my family had prostate cancer, or I don't have any symptoms, or, people would prefer, I don't want to know. I have cancer, I don't want to know.
Wow.
Yes, and so those are, it's really very sort of, I just go about my business. I don't really want to know about that.
And I have this question for you. What surprised you the most about the statistics on prostate cancer in the Caribbean?
I was surprised that the Caribbean countries had the highest mortality. I wasn't as surprised about, the incidence because of the high incidence of, or the higher percentage population of men of African descent, but certainly the mortality, in the Caribbean, even compared to, African countries, and that I thought was very surprising. That because within the Caribbean, the mortality is even higher than.
Higher than in Africa. Wow. Knowing what you know as a urologic surgeon, do these statistics make you angry?
Well, I think that I'm not so much angry. It makes me a bit sad, I have to say, and it really kind of motivates me to be much more aggressive about sort of spreading the word that this is not something that men should die from. And so within the Caribbean, when you think about, there are just a number of things. I think education is a huge component. Dealing with, sort of biases and beliefs and stigmas is a huge component. And I think that combating that really requires education. Access to resources. I mean, when you think about screening for prostate cancer, it can be an expensive endeavor, and so access to the appropriate opportunities for testing, for biopsies, for the various types of services, for various types of treatments, for access to even urologists. These are some of the challenges that within the Caribbean, and so it is. I mean, it's concerning, and I think what it speaks to is that there's so much work that needs to be done, and there needs to be a greater understanding in the community as to, especially to sort of combating and dealing with and really just sort of fighting against the fear and the misperceptions and the misunderstanding of what this is, and the real benefits of kind of early intervention and early diagnosis and early intervention needs to be emphasized over and over and over and over again. And so, I think that it, we are getting to the point where we have to be very more creative,
Mm-hmm.
much more dedicated and emphatic about kind of how we access populations to to get them to really kind of pay attention and to be very intentional about assessing the risk and making sure that their doctors are checking their PSA and making sure that they're getting regular rectal exams and not burying their heads in the sand that this is not something that's going to affect. What this data shows is that this is real. It's a real concern. It's a real issue within the Caribbean. So our men need to wake up and need to just embrace that. This is something that it's not the most comfortable thing to deal with, but it can be dealt with if diagnosed early.
What is radical? What is it? Prostatectomy?
Prostatectomy.
Prostatectomy.
So radical prostatectomy is a removal of the prostate gland. And so, as I described earlier, the bladder is attached to the urethra, which is the tube that runs through the penis where the urine empties through, and the prostate is located right at the entrance where the bladder and the urethra connect. And so, removing the prostate removes that gland from the base of the bladder and then reconnects the bladder neck to the urethra, so that the prostate gland then is no longer present and the bladder continues to function normally, which is that it fills and then it empties through the urethra out of the penis.
What are the risks of prostate surgery?
The risks of prostate surgery are, sort of several categories, and I think that there's certain of the risks that have, decreased as some of the more minimally invasive, sort of more highly technological surgeries have become more available. So the risk of a radical prostatectomy when we were doing open prostatectomies was bleeding. The prostate is located in a very bloody, very well supplied. There's blood vessels and veins, and so bleeding is one of the large risks. And then, as we talked about, the erectile nerves run right alongside on top of the prostate. And so during prostate surgery, those nerves are either cut, depending on the extent of the cancer. Techniques have been developed over the last 20 years to preserve the nerve, so the risk of erectile dysfunction or impotence related to prostate surgery has decreased because of better techniques of preserving those nerves. And with the robotic techniques, the ability to see the nerves better allows for better preservation of the nerves. So that erectile dysfunction is one of the risks, but that has become less and less. Incontinence is one of the risks. The bladder at the base of the prostate is the sphincter that controls the urinary outflow.
Mm-hmm.
And so when the prostate is removed, it is in very close proximity to that sphincter. That sphincter can be affected. So the continence mechanism, which allows the urine to stay in the bladder until you consciously relax that sphincter to allow the urine to empty, that mechanism can be affected, and some men will have what we call some stress incontinence related to having had surgery. And then other things related to surgery that are less common are things like nerve injuries, when we do dissections related to the identifying if there are any positive nodes or any spread of cancer. Those nerves sometimes that supply the leg can be injured and cause output drop, development of urine leaks with the anastomosis where the bladder and the urethra put back together. If that somehow is not watertight, we develop these type of leaks. We develop what we call lymphoceles as we remove lymph nodes and those lymphatic fluids drain, collectors can cause some issues. Pulmonary emboli are can be common because when we're operating near the prostate, with those compressions inside the pelvic veins can cause what we call deep venous thrombosis that can create blood clots that go to the lungs. And so the big risks, I would say, are the risks, and then of course the risk of any type of surgery, heart disease, and so on and so forth, risk of stroke, risk of heart attacks. But the big risks that we really discuss with patients are, bleeding, erectile dysfunction, incontinence, and development of any type of sort of collective urine or lymphoceles.
Can that be corrected though, the erectile dysfunction?
So the erectile dysfunction can be addressed, and so we have a number of techniques available to us, starting with everyone knows Viagra, at this point, so that the nerves, even if they're not completely, severed, you can maintain some nerve function, but still not be able to achieve a full erection. And so, with the advent of Viagra, Levitra, Cialis, these types of medications that allow, the sort of augmentation of erectile function, many men, if they're not able to have a spontaneous erection, will have improvement of their erections with the use of these medications. If those medications are not effective, then we can offer injection of what we call vasoactive medications that are injected directly into the penis in order to create an erection, or a medication that can be instilled into the urethra to also achieve an erection. If that does not work, we have what we call vacuum devices where there's a vacuum pump that's placed over the penis, and that pump is activated and it pulls the blood into the penis, and then there's a ring that's placed at the base of the penis to prevent the blood from flowing out of the penis so that the erection is maintained. And then if all else fails, then we do have surgical implants of devices that will inflate and deflate to create an erection if everything else is
What is one of the most challenging or complex urologic case you had, surgical case you had?
in relationship to prostate cancer or just in general?
Just in general.
Okay. Well, I mean, let's talk. If we talk about the prostate, I mean, the things that are challenging with relation to surgeries related to prostate cancer is one, if the prostate is very big. So if the prostate is very large and the blood supply is plentiful, then the risk of bleeding is significant. So very large prostates, can be very challenging to operate on. Patients who have, very elevated, body mass indices, and so obesity can also be a risk of prostate cancer. Can be very challenging to operate on, and so the robotic techniques, allows for some mitigation of that to a certain extent because you're not having to kind of go through a large wall of adipose tissue to kind of get down into the pelvis. In terms of the most challenging case that I've ever had, I think that's probably really difficult to sort of necessarily just pick one case, but certainly I think the cases that have been challenging for me are cases that are with very big renal masses, big tumors of the kidney that are almost kind of can extend up into all towards the chest with thrombus, tumor thrombus that can extend into the vena cava where having to control vessels that are difficult to get to because the tumor is so big. When you're taking kidneys out and the tumors are very big, to be able to get down to the aorta, to the vena cava in order to identify the vessels and transect those vessels can be extremely difficult. Can be fraught with a lot of elevated heart rate as you deal with the bleeding that can result from dealing with those very big tumors. So I would say that probably cases where the tumors are just very large that make it difficult to pass the vessels are the most challenging cases that
I want to shift gears a little. Can you tell us what was your motivation behind writing those three children books?
Where is my motivation? There is a quote by Woodrow Wilson that I love, and it says, you are not here merely to make a living. You are here in order to enable the world to live more amply, with greater vision, with a finer spirit of hope and achievement. You are here to enrich the world, and you impoverish yourself if you forget that errand.
Oh, I love that.
And so, when I think about my motivation, I look at the faces of my son. I look at my nephews. I look at, the children who are, part of our community. I look at the faces of the students and the generations of kids. And, and I think about how do I, in addition to working with my patients, in addition to, impacting at that level, how do I make the world a better place for the next generation? And those are the things that inspires me to write, to share what I know, to share my knowledge, to touch children in a way that hopefully inspires them to want to achieve, to be excited about learning, to be excited about giving back and making a difference when they get to be, wherever they end up in life. So, that's my motivation. It's just those faces of those children and the opportunity to think that, when we leave this earth, we leave it a better place than.
Where can someone find your books?
My books are available online through Amazon.com. They're available on my website, www..
Do you have any close by?
Oh, sure. Absolutely. Always. Oh, hang on.
All right. Take your time. Here we go.
Okay, here we go.
One at a time. Start with number one.
Okay, one. Number one is Dr. Didi Dynamo's Mission to Pluto.
Mm-hmm.
And, quickly, and we've had this conversation before, but, one of the things that struck me as, I've been involved in volunteering and community organizations and working with girls and working with kids and mentoring, et cetera, was that, one, that there was no powerful can-do, female character that sort of really inspired girls to, be all that they can be. Two is that I love reading and I just wanted kids to just enjoy reading as much as I did. Three is that, it's so important that we are represented, our kids are represented in children's books. Like our kids often must be able to look and see, a brown face flying across the screen and know that that's a powerful superhero that can do anything that they want. Four is that, the issue with girls in STEM, science, technology, engineering, and math, and what is it that seems to be creating this, stereotype and bias against being able to do science, technology, engineering, and math. And I wanted to try to really reach kids earlier to have this become a natural part of who they are, to have them have an affinity to science and to love it, and not to be, affected by a lot of, the kind of stereotypes that girls can't do science. And five was just to kind of share my love of science, of surgery, of medicine, and to just find creative ways and a platform to really get kids excited about, all of the things that I just talked about. And so that's why I developed this little girl surgeon. And so she uses her, her surgical skills, because I figured if I was going to write, I should write from what I know and I can. And so that's how I came up with the character. And the second book is, so the first book was Mission to Pluto. She was, Pluto was very upset that it was downgraded to a dwarf planet, and so she, uses her surgical skills to address Pluto's issues, and brings into, kids into contact with what are planets, what are dwarf planets, what was the issue with Pluto, why was Pluto downgraded, and so on and so forth. Dr. Didi Dynamo's mission to meteorite mission, dealt with the 2013 Challenger meteorite collision. And one of the things that, it's almost like my husband says, this is like writing calypso, because, in the Caribbean, many of our calypsos are political commentaries. They're commentaries on sort of what's happening, currently. And that's one of what I try to do with the books is
Oh,
really,
that's interesting, Oneeka. I never knew that.
yeah, it's to really reach through to, kind of what's happening currently, what's happening in science
Oh, that's
currently, what are the
interesting.
concerns, and how do you bring kids into context. So a lot of this is a commentary and a statement about, the importance of being in touch with what's happening, the fact that science is dynamic, it's constantly changing, and our kids need to be aware of that. And so this is a way of really drawing kids into some of the current um, some scientific discussions, etc., etc. The third book is, the Dr. Didi Dynamo Saturn Surprise, and this is, um, based on, a lot of the information that we have been, acquiring because of the Cassini-Huygens spacecraft that has been orbiting Saturn and delivering a lot of great information. And so this completes the space series. The next three books, which will be part of my environmental sciences series, will look at, the first set of the series, book in that series is going to deal with the declining bee population, the importance of bees, of pollination, and the whole sort of conversation of what's happening there and how can we potentially, solve that crisis. Number two is going to be, the environmental sciences series will deal with the global warming, set of concerns, and so we'll really bring that conversation into focus for kids. And number three in the series will deal with oceanographic pollution. And so those are all in the works. And then I move on to another area of science and
Awesome.
continue to build a platform for kids.
When can we expect number 4 coming out?
My expectation is that number four, I'm hopeful that we'll be out by June, with the beginning of the summer.
Okay.
And the second book in that series will be out by Christmas. So that's what I'm aiming for. If I can.
What is the website again?
The website is www.drdydynamo.com or www.dronika.com.
DrOneeka.com. Well, we're we're almost out of time. Actually, we are out of time. But I want to ask you one quick question. What still surprises you about your field?
Yes. I think what surprises me is that, and I shouldn't be surprised, but I'm always surprised that
That's
you know,
good.
we we continue to just make, so many strides in terms of how we, address disease, in terms of how we take care of patients, in terms of offering, new and different approaches and new and improved approaches to patients and patient care. And so every time I think, geez, well, we can't, this can't get any better, we come up with a better way of doing something. And so, that is something that I think is, is is a bit surprising. Because, when are we going to get, geez, we're still learning more. There's still more to learn.
That's healthy. That's a healthy space to be in. To
Yes.
be. If you could be, and this is the last question of the evening, if you could speak to a room full of Caribbean men, what would be your message?
My message would be that prostate cancer is a significant issue for men in the Caribbean, that men die from prostate cancer needlessly, and that there are ways to identify prostate cancer early that makes it treatable and curable. And so you got to get moving. You got to let go of all of the stigmas and all of the, kind of beliefs that you have about having yourself checked. You have to get rid of the fear of being treated for prostate cancer. You have to get rid of the fear of potential side effects from being treated for prostate cancer. And you just have to kind of stand up and step up and get yourself evaluated and assessed. And that it's never too, we're seeing, we've seen patients in their early 30s with prostate cancer. So that this is not a disease of just old men. I mean, the disease of old men for prostate cancer is likely to be a disease that's not that clinically significant. The disease in younger men is the disease that tends to be much more aggressive. And so, from the time you hit, certainly for men in the Caribbean, from the time that you are 40, you need to have a digital rectal exam and the PSA annually.
Well, as you had a good laugh, Monica.
I am always, I am always laughing. I am always, in some, to some shape or form, laughing. So most days I have a good laugh about something.
Good. I'm glad to hear that. And Onika, it was some challenge for us to get a date for you to come on because you have such a busy schedule. So I'm really honored and very grateful that you made the time, and especially because this is Women's History Month. So thank you so very much, and keep up the good works. And please, when the book come out, let me know.
Thank you. Well, Selwyn, thank you once again for having me on. I mean, you're doing some awesome work, and I'm always just so blessed and happy to be a part of the show. And, we're here to make a difference. And so if I'm hopeful that someone, watching this, someone hearing this would be inspired to share it with their family, would be inspired to, get on the male members of their family to get checked, to get their prostate checked, to get their PSA done, and to not wait until it becomes symptomatic because by that time it's too late.
All right, good night. And this is Selwyn Collins saying, fear not what fear whispers to you, fear your obedience to it. Good night, Oneeka.
Okay, good night, Selwyn. Thank you very much.
Bye bye.
Mama,